fun meeting people and seeing people they haven't seen for a while. Pleasure in state government policy, especially healthcare, given the amount of attention healthcare policy is getting, well deserved. So this is a great conference to have, and I want to thank everyone for coming. I'm Bob Megna. I'm director of the Institute. And, you know, a few of these remarks are based on promptings I got from Courtney about things I should remind people of, one of which was how long I've been doing this. I started in 1978. So I think I talked to Bruce in the back. We might be tied for I don't know. It's not a good thing. I was going to ask everyone who was born after 1978 to raise their hand, but I'm not going to do that. So I think 40 long enough, but administration of healthcare has been an issue that entire time. And it has gone through different phases and different levels of government and different governors and different administrators, but it has been at the top of the list. People forget in state government that after you've looked at healthcare and education K through 12, the rest of the budget is often an afterthought, right? And so I think it's a critical issue and remains a critical issue. Most important, I want to thank Dr. Barbeau and everyone else in United Hospital Fund for helping to organize this and bring this piece to fruition today and the next meeting in New York City. I want to get started. You don't want to hear from me, but I do want to thank, and we are privileged to have Courtney Burke with us. We all know Courtney. She served as commissioner of OPWDD, as well as working on the second floor, and has worked within the industry for a long time. So Courtney's been responsible for a lot of what we're going to do today, and so we know for that reason we're in good hands. So let's get started with the first panel. And Courtney.
I think that's the first time I've heard out loud somebody say, I've been in the industry a long time. So thanks for that, Bob. Well, good morning.
Still don't beat me, Courtney.
No, good morning, everyone. It's great to see people in person, and I know we have a number of people who are also watching live stream United Hospital Fund to say a few words about that when we conclude today so that you all know that this is an ongoing conversation, and I think it should be. But the reason we're here, I would say there are two main goals for convening this conversation. The first is just to put a spotlight on Medicaid and the importance of the program for so many people across the state. Part of the reason we have the panelists that we have today is because Medicaid is important to a wide range of people in New York State. I think most of the people in this room or those listening online know the facts about Medicaid. It's close to 7 million people in New York State, 70 million nationally who depend on it. You also hear a lot about how much New York State spends on Medicaid. We're always pointed to as highest per capita spending and so on. One fun fact that people don't realize, though, is that with all the attention and all of the people who depend on Medicaid, we rank close to 46, near the bottom when it comes to spending on Medicaid administration. Now, some people would say that's a good thing, right? We're very efficient in what we do, but yet you look at the size of our program, and if you put that in perspective, the size of the Medicaid program, and you're thinking, well, you know, is administration important or not? Well, if you're running a company that would actually fit above Tesla and Target on the Fortune 500, perhaps you should be caring about the administration of that program, let alone that company. And in New York State, I don't know if we're really thinking as much as we should about the importance of Medicaid administration. So this conversation is meant to highlight why administration is important. So in order to put together my thoughts for today, of course, I asked ChatGPT, what are the things that are important about Medicaid administration? And so I just want to go through the 14 things that ChatGPT gave back to me. Number one is policy development. If you don't have enough people, you don't have good policy development. If you're looking at things and how they impact individuals, eligibility determination is another thing that Medicaid administration does and is important. Enrollment management for people, making sure that they're getting their benefits timely. Provider management, we know what a big network, and many of you in the room are providers. Claims processing, imagine that, getting paid for the services you're delivering. Quality assurance, financial management, data management, compliance and auditing, stakeholder engagement, training, technical support, outreach and education to members and providers, policy evaluation improvement, and interagency coordination. That last one, having worked at an agency that was highly dependent on Medicaid for the people we supported, very much appreciate that one and think it's often overlooked. So I hope you're hearing me that it's an important topic to talk about. And before I introduce our panelists, one other seed that I want to plant is that we often in New York don't always look outside New York because we're big, we have everything here, we're a leader in so many things. I would make the case that sometimes it helps to look at what might be working well in other states and that there are different ways of thinking about that. If you look, just taking a sample of some other states and how they administer their programs, they are different. So in New York, you all know that Medicaid is housed within the Department of Health. The Office of Health Insurance Programs, which oversees the over $100 billion program, is one of 9 offices within the Department of Health. So, you think about that and some of the other ways that programs are administered or agencies are governed in New York. There are different ways of thinking about it. And I'm not here today proposing that we think about it one way or another. Is there a different structure? Should Medicaid be in DOH? Should it be outside of Medicaid? It's done differently in different states with different outcomes. But I would just ask the audience to think about, is there a different way of doing this that might be more effective? Another thing that I'd like the audience to think about is the beneficiaries, and that's why we have Lara here today to talk about that perspective. And most importantly, now is the time that we should be having this conversation. You all know what's happening in Washington. It's hard to see a scenario with the Senate now taking up the One Beautiful Bill Act, how Medicaid doesn't walk away from this without being cut in some way. So I think it's a timely way to have the conversation. New York State is probably going to have to deal with some of those cuts in the upcoming year. And how we deal with the cuts will be important for Medicaid administration. If you look at the Office of Health Insurance Programs within DOH, the vast majority of the employees are doing that frontline enrollment function. There's only about 70 or so staff who are actually overseeing the 14 things that ChatGPT told me they need to be doing. 73 people over a $100 billion agency, it's important to think about what are the implications of that. So with that opening, I want to introduce our panelists, and I'm not going to read their full bios, which we did actually put on the website. I will tell you that they're all impressive people that I have met over the years, and they all have different points of view or professional experiences from which they've had to deal with the Medicaid program. And because of that, I actually want them to introduce themselves by telling you from the different perspectives they've had in their career, why is Medicaid administration important to them? So just so you know who's up here, and then we'll start with you, Jeff. We have Jeffrey Brenner, who's the Chief Executive Officer for the Jewish Board. Laura Castle, who's the coordinator of Medicaid Matters in New York. And Chad Shearer, many of you know Chad through the work that you've done over the years, who Senior Vice President for Policy and Program for the United Hospital Fund, but Chad has also worked in a number of other states. So I'm going to kick off this panel, and again, we will have time for Q&A when we're done, by asking each of them to talk a little bit about their previous professional experiences and how they've viewed Medicaid and why it's been important to them in those roles. So we'll start with you, Jeff.
Great. Thank you very much. Thank you to the Rockefeller Institute and United Hospital Fund as well for putting this together. So as a young 28-year-old family doctor, I landed in Camden, New Jersey, which at that time was one of the poorest cities in the country. and I was seeing kids, adults, and delivering babies, mostly for a Medicaid population. After a couple of years of doing that, I broke off and formed my own private practice in Camden. If you're looking for a good business opportunity, I don't recommend it, but it was an amazing vantage point to think about Medicaid, understand Medicaid, and literally be put on hold, on the phone with them, run to the mailbox waiting on a check from them, make payroll, and really think deeply about what it means to be a Medicaid provider. I saw kids, adults, and delivered babies and got a very intimate view of the Medicaid system, the diversity of care, all the different people that Medicaid takes care of. Medicaid went through hard times in New Jersey, and they unilaterally switched everyone, all the primary care providers, from capitation to fee-for-service. And I was getting cap checks one month, and the next month getting $19 to $25 a visit. So within about a year, the practice unraveled financially, and I ended up having to close it. Very painful process. But the good news is it freed me up to do other things in my career. I ended up running a very large outpatient hospital-run clinic in Camden, so worked on the senior team at a hospital, and then eventually worked for United Healthcare. And I was on the senior team of Community and State, which is the Medicaid arm that runs Medicaid all across the country. We had contracts and a health plan here in New York and in many, many other states. So I've gotten a chance to see this very interesting, amazing program as a frontline provider inside of a hospital and inside of an insurer as well. And I've also gotten to see the average age of Medicaid directors plummet year by year by year, and the experience level plummet. When I was at United, I watched the many different states we interacted with, and there were states that intimidated us and states that we ran circles around. And what you realize when you're at United, we count our profits month by month by month by month. And we get our financial reports month by month. And the people, the counterparties that we're working with in those Medicaid agencies are understaffed, poorly paid, and really at a tremendous disadvantage to run a system with such wealthy and powerful companies. So we'll talk a lot more about that, I think, but I think that's a good place to start about my vantage point. Okay.
All right, thank you. Thanks very much for having me today. I'm really pleased to be here to bring a consumer perspective to the table. I am staff to the statewide Medicaid Consumer Advocacy Coalition. So I have many years of experience now of looking at and participating in and pushing forward the many ways that Medicaid impacts on people who are covered by Medicaid or served by Medicaid in some way. And so I have a few different areas, I would say, that are really key to how Medicaid administration impacts directly on people. And they're not really in any particular order, though I do have some thoughts about kind of how I would prioritize them. So consumer engagement is really key to what Medicaid Matters is and what we do. And there are a lot of academic definitions of what that means. There are a lot of different perspectives about how to make sure consumer engagement is a meaningful thing, and how consumers and their advocates are engaged in a meaningful way or not in the process of administering Medicaid does really have an impact. And like I said, that's really at the core of what we do as a coalition. That's what we prepare our coalition members to do in their work as Medicaid advocates. And that's really central to what we believe is how people can more successfully be covered by the program, access their services, et cetera. And that is through, making sure that consumers and their advocates are part of the process of Medicaid administration. It's already been mentioned here, and I have a feeling this is going to be part of, a larger theme that we explore here today. And the staffing of the program is really vitally important. And we've seen across the health department, including at the Office of Health Insurance Programs, how diminishing the level of staff has impacted on the administration of the program. And that has been, we have seen how that has been detrimental in a variety of ways, including in, implementation, oversight, program development, policy development, et cetera. So really across the board. We're going to get into Medicaid managed care today as part of one of Courtney's questions later on. And the administration of managed care, I would say, is another area that has impacted on people's access to services, both good and bad, that we'll explore a little bit more today. And that's definitely an area where, people's lives are directly impacted. A couple more here. The data and access to data and the overall theme of transparency has been something that has come up in our advocacy over and over again over the years. We believe that having an understanding of what's happening in the program through data is really important because we bring anecdotal evidence, which is very valuable, we think. It brings the perspective of people who themselves are being impacted by policymaking and administration generally. And understanding what's happening in the program at a deeper data level is much harder to understand when you don't have access to it. And I would argue that, understanding what's happening in the program is really very important in making advances in the program and figuring out where systems changes could be made. We also have observed that the way that policy is made in the Medicaid program really happens less and less, unfortunately, by the Department of Health and more and more through the division of the budget. We really have argued over the past few years that it really would make a lot more sense for it to be a little more bidirectional and a little more of an opportunity for the health department to drive policy rather than the fiscal staff. And then I would just add, before I became staff to the coalition, I worked for several years for Assemblymember Dick Gottfried, who was the longtime chair of the Assembly Health Committee. And that certainly gave me, that's where I started to learn what Medicaid was and how to draft bills that change that amend the social services law. And working for someone who really espoused what it means to engage consumers in the legislative process, and learning the importance of bringing all stakeholders to the table and bringing all perspectives to policymaking was something that really has grounded my thinking about policymaking more generally, and I think is really instrumental in the thinking that I have about consumers, consumer engagement, and how people are impacted by policymaking.
Great, thanks, Laura. I'm Chad Shear, to the whole staff at Rockefeller Institute, and especially Courtney for partnering with us in this effort. For those of you that might not know UHF, we're a 145-year-old nonprofit dedicated to building an effective and equitable health system for all New Yorkers. We do this through a mix of research, convening, and running on-the-ground programs across our three key focus areas: coverage and access, quality and equity, and clinical community partnerships. So I've been doing that now at UHF for surprisingly more than a decade, with a real focus on New York Medicaid. But I do have a unique history that I think will be helpful to this conversation. I cut my teeth in DC working for a California member of Congress, learning about the crazy or very unique, or whatever you want to call it, county-operated plan system in California, and responding to the challenges faced by our constituents on the ground, and the providers and plans that were constantly hitting us up, asking us for changes in the Medicaid program at the federal level. From there, I went to the Center for Healthcare Strategies in New Jersey, which works with state Medicaid agencies across the country. And I think primarily there, I worked to help lead the Medicaid Leadership Institute. So we supported Medicaid directors across the country thinking through kind of their myriad operational and leadership challenges, and really kind of identifying all of these administrative barriers and how do you get through that effectively, to Courtney's point, as the leader, the CEO of a Fortune 500 insurance company. And then I was lucky enough to move over to another Robert Wood Johnson Foundation funded program that was helping states implement the coverage expansion provisions of the ACA. So working with states across the country on how do you expand your Medicaid program while also standing up an exchange, and hopefully doing some coordination between those two things, which we achieved in some states and not in others. So through all of that, I've seen upwards of 20 state capitals, and the real reasons why people say, if you've seen one Medicaid program, you've seen one Medicaid program. So I'm just really excited about this conversation and to bring some kind of multi-state policy perspective to the discussion about the importance of administration.
Great. Great. So I should have mentioned at the beginning that my day job, I work for an organization called Sachs Policy Group. We're a consulting organization, and I work with a number of different providers in the Medicaid space, from Human Services, Jewish Board being one of them, to behavioral health, to providers for services for people with intellectual developmental disabilities, and so on. So just wanted to make sure I mentioned that. But because of that, I do see a lot of priority areas for them in terms of what they want to see work better. Obviously, providers want timely pay that's more accurate for the cost of the services they're providing. But the panel, as we went through this morning and hearing about everybody's different backgrounds and how it connects to Medicaid, you mentioned some other things about the importance of coverage and enrollment, the importance of transparency and access to data. There's a lot of other things that if Medicaid is working well, really matter. And I would say being able to hire the staff that you need in a timely way to run the program would be one area. Coverage, obviously, and transparency of data being another. I would also say being able to hire the right people at the right amount with the right qualifications, which, having worked in civil service, I know can be difficult. But there's also things like, how do you innovate in state government? I mean, how is that possible? How do you have more efficient procurement? So given the list of things that, and there's more, but there's outcomes. There's looking at the quality of the services being delivered and so on. If you had to pick one, and if you can only choose two, that's fine, but this is supposed to be more of a lightning round of which of those do you think is most important to you, and maybe why it's most important to you? I don't know if I want to put Dr. Brenner on the spot first, but maybe we'll start with you.
I think a lot about accountability. We chose about 35 years ago to do more outsourcing in government. I'm not inherently opposed to that, but outsourcing requires a very different infrastructure, a different philosophy, and a different approach, which is vendor management and procurement. And I don't think we ever made the procurement side sophisticated enough for the rate of growth we've experienced in Medicaid. So if we're going to procure a $100 billion program, you've got to be really sophisticated at it. So let's do a counterfactual. Let's imagine that the MTA was run by the Department of Transportation of the state of New York. Let's imagine the Bridges and the Port Authority was run by the Department of Transportation of New York. It'd be hard to imagine all the procurement that they have to get done. It would be hard to imagine all of the airports being run by the Department of Transportation of New York State. So, we've really got a tremendous procurement problem that in my mind is at its heart about accountability. So there's a whole execution piece, which I think you're getting at, but if you can't hold your vendor accountable and stand up to your vendor, and your vendor should be a little bit afraid of you, and your vendor should be afraid of you. At United Healthcare, the 5th largest company in the country and in the world, we were afraid of Arizona, we were afraid of Tennessee, we were bewildered by California. We didn't know what to make of California. But I don't think we were intimidated by New York. And that's a problem, because your vendor should be intimidated by you. And And it comes down to capacity, it comes down to staffing, and in the end, it does come down to salary. Is can you pay enough to get the level of experience that you need? And the question is, should Medicaid directors be at the beginning of their career or at the end of their career? And if you're at the beginning of your career, you're going to be wondering, if I hold these vendors accountable, if I stand up to the hospitals, if I stand up to the labor unions, if I stand up to United Healthcare, what's going to happen to me? If I stand up to pharma, where am I going to go work? I've just truncated all my job possibilities. But if I'm at the end of my career, I don't care. I'll hold them accountable. So, there's an execution piece to this that's really important, but I think much more important is an accountability piece of how are we holding our vendors accountable.
To respect the request that this be a lightning round, I'll just pick one, and that is data availability and transparency. For the reasons that I mentioned before, we, as an advocate community, have really struggled over the years with having a deeper understanding of what's happening in the program without access to more data. And data is something that is costly to run yourselves, difficult to keep on top of, but it does exist, and having it be run more regularly and reported in a more transparent way would definitely, I think, allow improvements to be made across the board. And I would, because we're in a lightning round, Courtney, I'll just add, I do have some comments about procurement, and I think we could certainly save them for another time. But that, I think, would be maybe a second.
Well, Jeff kind of had two, so you can say them
Okay,
now if
I'll
you'd
say more. In the accountability and procurement space, and I realize we're going to get to managed care in a moment, Medicaid Matters has not taken a formal position about whether to procurement for the managed care program. And we examined this inside and out. We had hours and hours of conversation amongst ourselves, within the coalition, with other partners externally, and we ultimately decided to make a statement instead about quality in Medicaid managed care and how we think quality needs to be, more of a focus. Yes, of course, procurement could bring greater quality, and to Dr. Brenner's points, the state needs to be equipped to carry out a very, efficient, strong procurement program that at the time when this conversation last came up, we didn't believe was yet in place, and we really felt was really too risky of a venture at the time to take a position in favor of procurement. But we have seen through all of those conversations and a lot of deep diving into what that would mean, that procurement in Medicaid managed care probably would make a big difference and would increase quality for everyone.
Good news is I can lightning around this because those were my two. I'm just going to add a little bit to Dr. Brenner's and kind of how it plays out in practice. Because you have to create so many workarounds from a hiring perspective, you effectively three classes. You've got your civil service and all that it takes to do what you're trying to do to build up your civil service spots, while you're dealing with a whole kind of professional class of consultants that to some extent you treat like staff and maybe even feel like they're on staff, but they aren't actually your employees, they're consultants. And then you've got all these other workarounds like research foundations and the right people on board to do what you need to do. And the fact that you've got this kind of tripartite system just makes it all that much harder to have the people you need when you need them, where you need them to do the job. So it is the workaround that has worked, but it's probably not the best approach.
Yeah. So who knew that was going to be the most popular answer about, but that's great. Thank you for your perspectives. It's hard not to mention what's happening at the federal level right now. And when New York has faced any type of financial crisis in the past that's impacting Medicaid, or another significant issue that's difficult to deal with, there have been different approaches to it. For those of us who have been around long enough to remember the Berger Commission, that was one way of dealing with an issue that directly impacted facilities, hospital. There was also the Medicaid redesign team, which was a more collaborative approach with industry. given what's happening at the federal level, I think Medicaid administration and how we might approach this is going to be important. And I'm just curious to hear each of your views on what role administration plays in that and how we might approach the impending cuts that are on our way. Dr. Brenner, are you willing to go first again? Seems like we've gotten into a steady flow order here. Maybe we'll mix it up. Next question, Chad.
I think the requirements are going to be really complicated to administer, and the quickest way to make cuts is to throw people off the rolls. It's probably what the state's going to do. At the same time, the penalties for covering people who are undocumented and all the new paperwork requirements are going to be complicated to administer. So I think the most likely outcome of this is going to be a big reduction in the number of people covered, because the quickest way to go from 1 month to the next month and cut your budget in Medicaid, trying to cut fees, trying to cut service package, trying to reprocure things, like that stuff takes a long time. Trying to change your drug benefit, I don't see how else they're going to cut this without cutting people off the rolls. And they may be very private about it, so you may not know. To your data point, you just slow down the knob of processing applications and speed up the knob of throwing people off the rolls. And that's a relatively invisible process. It's much more visible to cut fees, to cut benefit design, to cut drug benefits, things like that. That's far more visible.
The work that Medicaid Matters has been doing on the federal advocacy over the last many months has been extensive, and understanding what the impacts will be here in New York. I get a pit in my stomach, and when Dr. Brenner just started, it all just sort of flared up a little bit. And I know that there are many people in this room who are losing sleep these days because this is going to hit our state in very, very real ways. And we all have a role to play in doing whatever we can to mitigate the harm in the next few weeks. I am going to, however, bring a bit of a more positive spin on this to say that compared to other states, I think we're going to, I'm very afraid people are going to lose coverage. I'm very afraid of what the cuts will mean for having to, potentially rein in the program in a variety of ways. And I'm not just saying this because the staff is here, and I know that this is a state Medicaid program staff that is dedicated to keeping people enrolled. And we've seen many examples of this. The unwind, which was the process for unwinding all of the rules where people could stay enrolled in the Medicaid program during the federal public health emergency. The process that the staff undertook to make sure that people stayed enrolled in the program was incredible. And so that example alone really gives me a lot of faith that we have the right people. We don't have enough of them, but we have the right people in the state of New York. I know they are already working on, if we have to implement work requirements and we have to do, more frequent redeterminations, what are we going to do to mitigate the harm and make sure people are going to stay enrolled? In some states, I'm sure there will be a paper form that someone will have to fill out to, or have their, let's say a child care worker, and they have a parent sign a form that says, yes, this person is working, or, a caretaker, or whatever the case may be. Any of those people who would be exempt from work reporting requirements under the new rules. There are a lot of states who are just going to say, fill out this form and get it to us, figure out how to get it to us by such and such date or you're off Medicaid. And I already know that in this state, the staff will work as hard as possible to make sure that there are automated ways for that to happen. And we can, make sure that it will happen in ways that will not burden people and will cause, as few people to lose coverage as possible. And I know that it won't just be a form that they'll have to fill out to make, to prove that they're exempt from the requirement. So that, I think, is my biggest example, and something that I sort of take away as like a ray of hope that we know in New York we have the right people that are really trying very hard to keep people enrolled.
Exactly the example I was going to use, and as we think about kind of the administration of that, the red tape, will be required. It's how the state responds to that, and we're lucky that we have a great mix of kind of existing data systems. We have people that think, very deeply about what are the workflows from a consumer perspective that will actually, make this as least painful as possible, all with the view of keeping as many people covered as possible. But you think about that from an administrative standpoint, this is an opportunity to think about kind of administrative simplification from the consumer perspective. To your point, automating workflows so that we use as much of the other data that's available to us to say, we know you're working 80 hours a week. You don't have to prove to me that you're working, 80 hours a month, not a week. Amir's working 80 hours a week. And I think this is the difference that you'll see between states. This is the difference between, a few 100,000 people maybe falling through the cracks in New York and nationwide, maybe 10 million plus people being removed from coverage, and in some states on purpose, to both of your point.
Mm-hmm.
Yeah, well, it's nice to hear some positive feedback for the state staff that are in the room, because I know they don't hear it very often, so appreciate that. So Lara, we're going to get to that question that I know you've been anxious to answer, and I'm going to let you go first on this one, but you had alluded to the shift to managed care. Managed care for all was the policy back in the day, and that has been a policy of some states as well. Curious to hear what you think the role of administration has been, what have been some of the pros and cons, and how could it be administered differently in the future? And we'll start with you, Lara.
All right, thank you, Courtney. Courtney mentioned the Medicaid redesign team. In 2011, the original MRT was seated, and I was on it. And one of the main initiatives of the original MRT was care management for all, as Courtney mentioned, and it came with a lot of promise. And unfortunately, we haven't seen the promises fulfilled for everyone. Managed care is, sorry, I'm fumbling with my readers here. It's a new phenomenon that I have to get used to. For some people, managed care has been a success. For people who, like me, I thankfully don't have chronic needs. I am able to, get my well child visits for my children and regular preventive screenings, and knock on wood, hopefully that will remain, we'll all remain healthy. And for people who really only need to rely on healthcare, on a regular cadence that they are familiar with, managed care can work pretty well. And for folks who need longer-term needs, who have the needs for long-term services and supports, we've seen that managed care has not gone as smoothly for them. And really, ultimately, what I believe this comes down to, and this is through many years. 2011 happened a long time ago now. Through many years of experience with hearing from advocates who work on the ground with people, both from like a community-based provider perspective, from legal services staff, who bring to the coalition what they're seeing on the ground. There are, I think, a few things that have already been talked about today that are really could really make a difference, and those are, the staff capacity at the health department. Again, I did not know, by the way, that the number of people who work for OHIP is 73. I didn't know that.
Well, it's a lot larger, but those who are in administration duties, not
yes.
frontline eligibility.
Yes,
I believe that's the most, around the most current number. You can correct me if I'm wrong.
And we have seen where we have brought issues to the table related to managed care, and the staff that's working in that division just does not have the capacity to be able to, dive in deeper into some of the things that we bring to the table. And that's they that's a general statement. They are able to, dig into a variety of things. But when it comes down to, potentially bringing more, it's staff capacity that has been an issue. And, being able to prioritize oversight when the staff is focused on implementation and regulation, and being able to prioritize enforcement and oversight is something that really could be improved upon. And ultimately, the structure of managed care is such that there are financial incentives built in to the structure and the design of Medicaid. That's not intentional, but that's the way that it's designed. And so those are some of the things that I think really impact directly on people and access to services the most.
Great, thank you. Chad, do you want to go next?
Yeah, just building a little bit on what Laura said, I think there is some benefit in Medicaid members being attached to a plan and the value that brings to them. If you look at the census data, you will always find an undercount of people on Medicaid versus what the administrative data shows. And the reason for that undercount is because people think they're on United. They don't know that they're on New York Medicaid United. And I do think there's some benefit from a member perspective to those people saying, I have the same insurance card for the most part that my neighbor who has employer-sponsored insurance and a great job has. So I do think there is some benefit to that from a consumer perspective. The challenges are myriad, and Laura highlighted many of them. I will say one of the biggest things is kind of the capacity from an accountability perspective to really understand what the managed care organizations are presenting in terms of rates and how they're thinking about the distribution of rates in the context of, the state having, many different rate cells for different populations. I'm not an actuary. I don't ever want to be an actuary. The state relies on an actuary. All states rely on actuaries to assess those things, but I think that's one area of expertise where it's not going to be feasible to think that the state is going to have, a powerhouse group of effectively actuary level people that are going to be able to understand what's underlying kind of all these rate submissions from the myriad different plans we have in the state. Thus, the potential for thinking about, is procurement a vehicle to maybe right size and get to the right level of kind of consumer choice, but also, feasibility for plans to have enough N in a geographic area where it makes sense from a financial perspective.
Dr. Brenner?
I think it's worth rolling the clock back a little bit, back to the 80s, and remember why we signed up for managed care. And, there was so much written, so much talked about. There was a lot of ambition about why we were going to shift the system. So at the heart of it, I think my colleagues, physicians, were abusing the system. And we had incredibly long lengths of stay in the hospital because you could get a click for every day that they were in the hospital. And the longer you were in the hospital, the easier you were to care for. And you just run by and see everyone. So incredibly long lengths of stay. We also had lots of cross-investment going on in the system. Doctors invested in all sorts of things. So tremendously inappropriate ordering of testing. And they were prescribing whoever the last detailer from a drug company that came in, they were prescribing that drug. If you look at all the top 10 drugs, it's all the top 10 marketed drugs. So managed care was an attempt to address that mess through tiered formulary, which is good for you. It prevents doctors from prescribing stupid drugs that don't benefit you. By pre-certs and pre-auths, it prevents doctors from ordering unnecessary testing on you. Bed day managed stuff. And it brought costs down. These companies got incredibly wealthy because they squeezed a fat system down and squeezed a lot of cost out of that. But I think and if you look at the contracts, the procurement contracts between the states and the managed care companies, they go on for thousands of pages. And I think states decided, well, if you solve those problems, can you solve all of our other problems? Healthcare is a mess. Can you solve all of those? And the contracts just go on and on and on and on. And I think what happened is those things work if you are Kaiser Permanente, where you're actually delivering care and you have a sizable percentage of the population. They don't work if you're one of 12 or 15 managed care companies with intermixing networks where a single doctor or single hospital could be a member of 20 different organizations. Each organization is a tiny sliver of their population. You can't move the care models around. You can't really change how people are receiving care from very weak data signals. So I think in our minds, we imagine managed care solving all these problems, and it's actually really good at solving a very finite set of problems if they're not a staff model HMO that also delivers care. So the first step states need to take is dial their ambition back, make these contracts much simpler, and get clear about what is managed care going to do for you. They're going to pay claims. It turns out that paying claims when there are 20,000 prices is really hard. Preventing fraud, the amount of fraud in Medicaid is mind-boggling, and the fraud is so clever. I never thought about fraud until I got at United Healthcare, and you wouldn't believe the crazy fraud schemes. Someone has to crack down on that. Someone has to manage a formulary with all the biologicals. That's pretty complicated right now. So I think the first step to all this would be to dial back our expectations to a clear set of things that they do well and hold them accountable for doing those things, and have way fewer of them. There's no reason to have the number of Medicaid plans if all you're trying to do is get them to pay claims, manage a formulary, do pre-auths, pre-auths, and those things. You don't need so many of them. Like, why administer such a complicated program? It doesn't make any sense. And get away from the idea that they're actually going to fix care. I want to mention one other piece where the most successful thing I saw at United Healthcare that Medicaid ran was MLTSS. MLTSS is long-term supports. It is a model to focus on inappropriate utilization of nursing homes. There are certain states, as everyone knows, the majority of the costs for nursing homes in states is paid for by Medicaid. And there are states that tremendously abuse this. There are lots of legislators who run nursing homes and expand the benefit. So you end up with this incredible utilization of nursing homes of people who don't need to be there. And the thing about MLTSS is that it's a rate cell. It's a defined rate cell with a defined benefit and a clear logic model. The logic model says most people don't need to be in nursing homes. They can live in the community. And then it pays a blended rate. So the managed care is on the hook if you go to a nursing home, and they benefit if you stay home. And the rate being paid is between the cost of those two things. And the goal of the managed care company is to repatriate you out of the nursing home, get you back in the community, or keep you from going to the nursing home by paying for aids or paying for a ramp or paying for other services. In states where MLTSS is implemented, nursing home utilization plunges. So, but I can't give you any other example where managed care, Medicaid managed care, is amazing. I can give you marginal benefits, a little bit here, a little bit there. But the thing about MLTSS is it's a defined population with a defined problem, with a defined logic model, with a defined payment model, and it's fairly simple what they're trying to accomplish. So, so back to my original point, which is let's get clear what managed care does and doesn't do for you, and let's just buy that. And then when you want them to do something, it's got to be the most boring, clear logic model in the world. Managed care is all about scale. It's not about sophistication. It's not going to innovate for you. Stop asking them to innovate. They're not going to innovate. United Healthcare is the most uninnovative place I've ever worked in my life, but it was huge. It's just a machine and it marches along. So to expect managed care to innovate for us, it's just never going to happen. Yeah.
Great. Yeah, very insightful answers. Appreciate that. And the discussion about managed care got me thinking about Arizona, which was one of the first states to go fully managed care, which got me thinking about other states. And I'm going to ask the panelists one more question. I have more, but there's so many smart people in the room. I wanted to open it up sooner rather than later. I can always go back to my questions if I want, but let me ask this one, and then we'll open it up to see if anybody has any questions. If not, I'll go back to my list. So we're talking about Arizona. Start thinking about other states. You all mentioned data transparency as being an important thing, which always makes me think of Massachusetts, where they have a unit that does just health analytics. It's called CHIA. and that alone has 80 employees just doing the transparency, the reporting, and everything else. I think about other states. What do I like about what they're doing? Washington State procurement came up much more than I expected it to today, and the importance of that. And they have an authority, and they have a very quick turnaround time on their procurement. I was going to pause there before I start talking about other states. Since a couple of you have worked in other states, and Chad, maybe we'll start with you. We'll mix it up this time, then we'll go the opposite direction. What did you like about some of the states that you saw where they had a feature or two that may be a good model to look to if we could aspire to actually be able to have that amount of staff at some point in time?
You hit on one of the great ones with Massachusetts and CHIA. I think something else that Washington does great is they've really leveraged their authority structure to somehow break down their governmental silos. And I don't know what it is about how they run their authority that exactly does that. But they've been able to pull together a lot of cross-agency data into a single data set, maybe even better than CHIA in terms of the depth of the data. They've got justice data, they've got housing data. They've really pulled together cross-agency data in a way that's then been used by the authority to make really effective programmatic and policy decisions. Also on the data front, just kind of an approach. I wouldn't say I'd necessarily ever point to Alabama, and I love them, and it was a great place. Montgomery is a very fun place to go see a minor league baseball game. The Biscuits, they're called. It's fantastic. But never did I think I'd go to Alabama, and the Medicaid agency would be leveraging what at the time was an extremely innovative kind of statewide internal IT structure that was really trying to do kind of cross-agency IT builds in a way that could bring data together. Now, did they ever get it done? I don't know. I stopped working with them. That's part of the consultant problem. So I don't know where it landed. But you think about kind of what USDS was doing at the federal level out of the White House, kind of trying to help agencies build the technology infrastructure, and to see that happen in states, I think that's something that could be great in New York. And there's just a couple other real quick examples. Out of Oregon, I think there is some really good things to think about from Consumer Advisory Council and consumer engagement as they do that at the Oregon Health Authority. And then also thinking about, prescription drugs have come up a little bit, and now that we've carved drugs back out, is there a Washington-style, prescription drug affordability board? How do we build on some of the things we're already doing in New York, whether that be the DFS Drug Accountability Board or our own DOH Drug Utilization Review, to think about, how do we do better administration for prescriptions in Medicaid?
Those are some great, solid, concrete ideas. Larry, you want to go next?
Yeah, I mean, I really don't have the capacity to, do analysis of what other states do. So I can't say that I have much to add here. But, excuse me, but, we do have, as state-based consumer advocates, we do have the benefit of having colleagues in other states. And so from time to time, we are able to, tap into our colleagues in other states that are doing other things. So I don't have specific examples. It's an area that we try to get into, but it's hard just given our capacity.
It's worth talking a little bit more about Washington State. So I don't think it's been mentioned. Their authority carves in their employee health benefits for state employees, as well as Medicaid, combines them together. That gives them a lot of purchasing power. It also gives them more administration and more sort of infrastructure dollars to work with. I want to talk a little bit about authorities and why it could be a beneficial strategy. I haven't worked inside Medicaid, so that's the one part of the system, but I've been friends and watched lots of people trying to run Medicaid, and from what I can see, it seems like whenever any major decision needs to happen, procurement or other things, that decision gets passed like a football around inside of government. So the finance part of government, the Attorney General's office may be involved in contract negotiations. It's going to go up to the governor's office for some decisions. So making decisions seems like a paralyzing activity because the decision is and the people that need to be involved, it's passing all over government. And in authorities, that doesn't seem to happen. So an authority is really a dedicated vehicle to solve a problem and to procure around that problem. So the New Jersey Turnpike Authority is now, the turnpike is, I don't know, like 100 lanes wide. They just keep widening it and widening it. And if you can imagine the size of the procurements to widen the highway and how complex those procurements are, if you took that turnpike and put it back in the Department of Transportation, you know, the AG's office is going to be involved, the budget office is going to be involved. You're never going to get procurements done. In Medicaid that sits inside of government, you see failed procurements over and over. Like the Pennsylvania Medicaid kept having failed procurement after failed procurement, where they legally have to start all over again and do the whole procurement again. That's not what you see inside of authorities. They do procurement all the time. And you have dedicated teams in the finance office and the budget office and the legal team who all they do all day are procurements. So it's a much smaller team. It's a dedicated purpose team to solve a specific problem. In business terms, there are functional org charts and divisional org charts. A divisional org chart is formed around a specific purpose, and an authority is a divisional org chart. In a gigantic state government, trying to pass decisions from one functional silo to the next functional silo is going to be paralyzing. So the other piece is that authorities have a lot more flexibility in their salary scales and in the way that they're managing employees. So salaries are higher in New York State authorities. The Medicaid director's salary and the salaries under them are going to be capped by the governor's salary, by the secretary's salary, and the whole chain of people above them. And then the third piece is that authorities often have boards. And I would argue that that in some sense, the governor's office and then the legislature is sort of the board for Medicaid right now and is trying to do strategy. But there's not a lot of strategy going on. At least with a dedicated board, an authority can have a group of people who love Medicaid, wake up every day and think about how to move that forward and develop a strategy for it. So three things an authority provides: better salary flexibility and personnel flexibility, a board that could deliver a clearer strategy, and the ability to execute on procurement would make a difference.
Well, for somebody who has never worked in state government, you have some very interesting insights. So thank you for those. At this point, I did want to pause and see if we have any questions from the audience. And please don't be shy. We've got folks in both rooms, and we have mics and people ready for your questions. Because you don't want to hear me ask more. I have more. All right, we got one. Two. We got two.
Dr. Brenner, Peter Wolf from United Hospital Fund. Why did Arizona strike so much fear into United?
They were a strong team. You know, they were a stable team. They, I think behind the scenes, were a well-paid team. And they just held us to account on every detail. We had one of our strongest Medicaid directors there to work with them. So it was a strong, stable team. Yeah.
Another one in the back.
Hi. You had mentioned at the beginning that sort of fiscal policy, or the budget office is involved in Medicaid policy as much as anyone else, and we're talking so much about the lack of capacity in Medicaid offices. And Jeffrey, your thought on authorities is a very interesting one. But I'm just wondering if the panel or anyone has any thoughts on, both in New York and other states, like what should Medicaid offices be doing to try to build capacity, and how to interact with the fiscal powers that be in government to sort of improve Medicaid as best as they can, especially going into this difficult environment. I'm sorry if that's like an impossible question, but let's put it out there.
Well, I'll actually start, and then look to the others, give them a second to think about that. Having worked in government, and I know that there are some folks from the Division of Budget here, and there's folks from DOH. It's a long process, and it's a dance, and it usually starts with the policy folks in the agencies talking to the budget people, and that back and forth, that dance, that battle happens for a good part of the year. as to, we want to do this, well, you only have money for this. You got to figure out where you're going to get that money from. Nobody sees that part of it. And then it comes to the governor introduces the budget in January, and there's a very short period of time where all of a sudden the folks from the Division of Budget and the folks from the agencies are united because they're battling it out with the Assembly and the Senate. But that's really the only time during the year, and you don't see that. But your question was really more about how do you increase that capacity, and so I'm hoping that perhaps the panelists have some thoughts or insights on that.
You know, the approach we were taking with the Medicaid Leadership Institute, I think, is the best, where it's not just developing the leadership of the Medicaid director proper, but thinking about the leadership team that it takes on the Medicaid side, and thinking a lot about what is the professional development that's necessary even for those executive level teams as they interact with people like Division of Budget. We've been very lucky in New York to have effectively fantastic CFOs at OHIP that have been able to go toe to toe, you know, in this interesting political environment. And it takes that, and it takes finding and training those people up and having a staff, you know, a finance staff within the division, you know, underneath that CFO who really know the program inside and out and can speak to it at that level with the executive.
Great answer. Oh, and I think we have some insight in the back of the room on this particular question. Bob?
So I get the issue, believe me, from personal experience with going from a governor's office to a division of budget to a health department and back and forth on trying to do a Medicaid budget effectively. How do you tell those actors in the public authority point of view that your role is not going to be what it was before? Because in a state like New York, I think that's a hard sell. So how do we sell them on that?
See, I thought you were going to answer the question. You asked the question.
The nice thing about the default is that the default's going to crash and burn. Like, does anyone think 10, 15, 20 years from now, the state of New York is still going to run its Medicaid? Look at the trend lines, look at the cost inflation, look at all the demands and the complexity. So the counterfactual is the default. And I just can't imagine the default here 20 or 30 years from now. It just doesn't look like it's going to survive in its current form. I want to address the one question about capacity. There's two ways to increase capacity. One is to hire more staff. The other is to say no. And what Medicaid needs to learn how to do is say no. And the best example I have of that is, and I'm going to hurt some people's feelings here, is the waiver. Right? The waivers, I bet, has sucked the oxygen out of the room inside of Medicaid for the last 3 years because it's so complicated to get waivers out the door, to get them approved, to negotiate. So, you know, there's opportunity cost, and most of Medicaid is struggling around how many hours in the day do you have, how many staff do you have, and what do you make choices about in your opportunity cost. And, you know, the best part about the waiver, in my view, was the expanded coverage for kids, you know, how you can't get thrown on and off Medicaid. But that's very simple negotiating. The SCNs are just, we're all going to, you know, on someone's gravestone will be, they finally got the heroes launched and the SCNs running. Really complicated stuff. I mean, I've spent my career on social needs. I get it. I understand. But it's really complicated. So I think a lot of the capacity question is really not, is really just about saying no and picking fewer priorities and doing them well.
And I'd make I guess a point on that, which is it's difficult to come up with policies that are really about changing the system long-term, like the 1115 waiver that you reference, building a social care network, something that is much needed in general, when you're dealing with a yearly budget. It's very difficult to reconcile those two. I don't know if any of the other panelists had a response, and then we'll go to the question here. Any other thoughts?
That was a good segue, I think, into my question, actually. I spent 13 years with New York State, started with OPWDD, moved on to DOH, actually, in OHIP, working on the ACA, and was very fortunate to have been a part of that team, and then moved on to OMH for the last 8 years I spent with the state, and am now part of the SCN. But I couldn't agree more with the sentiments around procurement. I have dreams of being on the Procurement Council at some point in my career. But I'm wondering how that looks financially when we're talking about building up state employees. I couldn't agree more. I left because of frustration in the system, and the inability to grow and support staff is an infuriating thing. But how do we fiscally support that? Because I was a fiscal person too, obviously, in procurement. And gaining the strength and talent to do what you're talking about, attracting those people to be state workers. How do we do that fiscally and also programmatically? How you keep people? I felt terrible sometimes leaving the state with my ideals, but at the same time, sometimes it is screaming into a void.
There are lots of well-run authorities all over the country, so the template for an authority exists. I think this is a political problem, which is letting go of control of the Medicaid budget is a pretty big loss to the Department of Health and a loss to the powers that be in the state of New York. So it's a political problem, not an execution problem.
Okay. Doesn't seem like there are any other thoughts. We have another question.
Yeah. Hi. So thank you, everyone. This was really insightful. I feel like between like Laura and Peter that I'm in the room with like my Medicaid teachers here. So just a quick question. You touched on automation and data and transparency. Are there specific areas where you think there needs to be improvement?
I can start there. There are a variety of different places where, from an advocacy, consumer advocacy standpoint, we have, taken a look at maybe how automation could, serve people differently. There are things that I actually don't know where currently the WIC program and the Medicaid program are trying to figure out how to do data matching to make sure that when someone is in the Medicaid so that they can do appropriate referrals. And so data matching and data sharing is something that is, has been something we have brought to the table. And I don't know where, the reason I'm saying I don't know where that one came from is because I don't think advocates can claim credit for that one. But there are a variety of other areas where, in particular, for instance, in the unwind, we saw examples of how the rules for the waivers that the federal government allowed during the unwind could be expanded or even made permanent. That would be the best of all worlds, I think, to allow for things like if you have zero income, you can be automatically enrolled. If you have SNAP enrollment. So looking at how when someone is already eligible for one program and their eligibility could cross over to Medicaid and vice versa is one important area, I think. And then in these examples that we've started to explore related to the possibility that we might have to have work reporting requirements, there are areas that Chad had mentioned where there are systems that already show a person is enrolled in school. And so how can the educational system talk to the Medicaid system so that that person doesn't have to produce the paperwork to show that they're enrolled in school? And that's one example. I mean, the list of exemptions, people who will be exempt from, hopefully we won't have that, but if we do, people who would be exempt from work reporting requirements and having to prove that, there are systems in place now that if the systems spoke to each other better, people wouldn't have to provide the documentation to show that they're exempt, from the work reporting requirements. So I think generally speaking, it's data and systems that already are built around, showing where people are, showing people, showing what people's experiences are and where they are, and cross-referencing them with Medicaid and making sure that the systems can talk to each other.
Question back there, and then I think we had one up here too. So,
thank you. A great panel session. Arturo Brito Children's Health Fund. We're a national organization based in New York City, where we bring healthcare services to children growing up in under-resourced communities. By background, I'm a community pediatrician, so naturally, I gravitate toward where I feel, and strongly both objectively and anecdotally, that there should be more emphasis on putting more services on the prevention side, particularly for children, because long term it definitely saves money and it creates a healthier group of children who later on become healthier adults. So simple, so obvious. My question is about CHIP, the Children's Health Insurance Program. I was struck, Jeff, Dr. Brenner, your comments about the rampant fraud in Medicaid, the inefficiencies, the complexities for procurement. Given that states handle CHIP in 50 different ways as part of their Medicaid program for the most part, is there any difference in that program that census every 7 years, been around since 1997? Or is the fraud the same issue? Are the inefficiencies the same issue? Or is there something a little different about that program, the way it's run, that might make a difference, particularly in New York, but around the country?
Behind the United, you paid claims every day, you did pre-auths, you did pre-certs. I didn't see, it was just another benefit package. It wasn't dealt with any differently. CHIP is just another defined population with its own rate cells, its own payment. It has a contract, but its contract didn't look that different, I don't think, than the other ones. So I didn't see it differentiated that much, other than all the attention on making sure, follow-up care for moms after the delivery, screening for depression. There are a set of the children's vaccination program and all the requirements about vaccination. But I didn't think it was that uniquely managed compared to the other products. These things are all called products inside insurance companies. So CHIP is a product.
Yeah, I would say even in the few truly separate CHIP states, the administration is very similar.
Yeah.
Very similar
to Medicaid.
Therefore, layers of complexity,
yeah,
inefficiencies, and as susceptible to fraud as the rest of it.
On a smaller population that's not as complex, so maybe not as much.
I'll give you an example of how clever the fraud is. There were two places in the country, Hidalgo, Texas, and Lakeview, New Jersey, that were hotspots that were like 10,000-fold for speech therapy for children. Like unbelievably high rates of speech therapy. So if you give the standard instrument for screening to a kid whose first language isn't English, they all fail it, and then they qualify for speech therapy. So every primary care office employed like 10 speech therapists, and all the revenue wasn't coming from primary care, it was coming from speech therapy. And cracking down on that took like years and teams, and then they go to the Medicaid director and appeal, and it was just a nightmarishly complicated to crack down on that. So that's how crazy fraud is. Yeah.
Interesting insight. Okay, we had a question up at all the way in the front. So we're only waiting for the microphone so the people who are watching the live stream can hear the question.
Thank you. I had a question building on Bob's point about how do you build political support for administrative changes? And in a program like Medicaid in particular, because it's been decades that we've been bashing bureaucracy and government can't do anything right. And so there's this real sense, and then we see Doge come in and, we're going to get rid of waste, fraud, and abuse, right? We're going to because government doesn't do anything right. So you have that problem. And then on top of that, you have the problem that Chad mentioned, which is a lot of people on Medicaid don't know they're on Medicaid. And more generally, positive programs tend to be submerged, like in the tax code, and we're gonna expand Medicaid, but we're not gonna call it Medicaid. We're gonna call it Badger Care, right? So that people don't know. So you have this positive programs that people like. People don't know that they're government programs, and the negative programs that people don't like the police coming in and doing bad things. They're very clear that that's a government program. So how do you build kind of political will? Generally, not just in New York State, among these people who don't want to give up power and control, but among people to say, look, government does things well, and we notice when they don't, like the streets don't get plowed, we very clearly don't notice. So how do you build the political support to do the kinds of things that we're talking about need to be done?
I'll start this one. The work that we're doing right now to defend Medicaid from federal cuts is a really good example of how to raise what you're talking about, essentially to say, this is what Medicaid does, this is how it's run, here are the people who benefit from it, and here's why we need to protect it. And I think in my experience and in the years I've been doing this, I've never had to focus on the importance of Medicaid and just the simple, basic impact that it has on people and that it's public health insurance. We've never had to emphasize that more. With that said, as long as I've been doing Medicaid consumer advocacy, part of our messaging has always been, this is health insurance. It's health insurance coverage that's run by the state. And the part of the reason we do that is because of these notions of Medicaid is something else. Medicaid is welfare. Medicaid is lousy. Medicaid, is expensive. Medicaid is this, that, and the other thing. We have found that the most effective thing to do is to bring it back to basics, to say Medicaid is public health insurance coverage, and the word public is important. Medicaid is public health insurance coverage, and here's what it means for people. And like I said, that has resonated in the work that we're doing now to defend Medicaid from the federal threats.
Most cuts in political systems, including New York, only happen when there are hard times, not good times. It's a very wealthy state. It's ridden on the backs of, a tremendous boon in Wall Street for the last 20 years. So there'll be some point when, the budget takes a downturn and hard decisions start getting made. So I haven't been in New York long enough to see all the history here, but there have been hard decisions made in New York, and I don't think they were made during good times. They were made during hard times. Forums like this start to set the table for widening the aperture of what possible solutions might look like. But we're about to go through a very hard time in Medicaid that opens up the opportunity space to have different conversations. Yeah.
Great. I see one more. Why don't we take one more question?
Thank you. Thank you for the questions and for the panel. I'd like to throw out this for thought also, that part of the administration, I think you teed this up a little bit, Courtney, part of the administration is the quality of the program. And what I've been thinking about is, in terms of the administration, where is the interface between the points that you've made and the agencies that are regulating care, and sort of shifting towards this one source of truth around the population, and decreasing administrative burden and regulatory issues where it certainly increases cost and creates a lot more confusion and churn for the population.
Anybody willing to comment? It's good observations, but
it's worth talking about where we've had a lot of success in quality over the last 20, 30 years. HEDIS has been successful. Medicare put a lot of money. They held back money, essentially. And the only way to get it was to achieve those metrics. The metrics are fairly clear in HEDIS, and there's a lot of money on the table for the Medicare Advantage plans, and they bypassed the doctors. They just went straight to the consumer. So they started mailing out Cologuard kits and mailing out, stool cards and mailing out mammogram slips and all this kind of stuff directly to people, and encouraging them to go and get these things done. And I think that's been very successful. A lot has been made of the nurses doing home visits in Medicare, and that's been focused on RAF and inappropriate risk adjusting. But the other half of their work was HEDIS, and that's been very successful, very meaningful, and it's resulted in a lot of Medicare recipients getting their quality scores increased where they might not have otherwise. So that's been incredibly successful, but the principles there are very clear measurement, a unified framework so that all the managed care companies are being measured in the same way, very clear money on the table, and they gave up on the doctors in many instances and just went direct to consumer. The best prevention efforts around the country tend to be driven by the staff or driven by the system. They're not driven by doctors. If you depend on us in every exam room to drive every quality metric, it often doesn't happen. It's driven best when the entire clinical system is driving it, and then the managed care company is aligned to that as well.
Great. So before we wrap up, and I'm going to ask for the microphone to be brought up here to Dr. Barbeau, because I'm going to ask her to say something about the next step and phase in this. I did want to say thank you to the state folks who came today. and let them observe that you have a room full of people and hundreds of people watching online who do care about Medicaid administration. Given the hard times that I know we're going to be facing in the coming year, I think your comment about widening the aperture of the conversation is a really important one of keeping the conversation open. We've always been very open in New York among the various constituencies who care about the program, and clearly many people do here today. So we're going to be continuing that conversation. Dr. Barbeau, if you'd like to say a few words about that, that would be great.
Sure. Thank you. Let me just start off by thanking you, Courtney, and the panel and the audience for a really dynamic conversation. I think it's important for us. I want to emphasize the point that you made in terms of we're in this room because we care about Medicaid and we care about the people that it serves. Certainly talking about Medicaid administration is not sexy. It's not what gets the headlines, but we can all agree that without healthy Medicaid administration, we don't necessarily benefit from using the dollars that we have at our disposal to the best benefit of the communities that we serve. So I think this was a really important panel and initial discussion on starting that conversation. And so the next part of the conversation will be in July at UHF. So hold July 9th or 10th. We're having some scheduling issues that we're trying to finalize, but July 9th or 10th will be the second conversation to dig in a little bit deeper about what are the options that some other states have chosen to pursue in terms of Medicaid administration. What are other best practices? Again, to advance the conversation. I think, you know, the point that was made here, and I've been in government as well, government doesn't necessarily work as fast as we would like it, and there's entropy that is in place to kind of keep the status quo, and that's why having these conversations in different formats is important, because we're not going to change things tomorrow, but eventually having more of these conversations with more decision makers, I think can help make a difference for the state. So thank you to the panel, and I hope that you all will join us in July for the second part of this conversation.
Thank you to UHF and Dr. Barbeau. Thank you to the Rockefeller staff for today. And most of all, thank you to the very insightful panelists today. Thank you.